And thank you so much for tuning in to another episode of Stuff That Matters. Today we are joined by Dr. Stephen Trzeciak. He's a physician scientist, intensivist, the Edward D. Viner Endowed Chief, Professor and Chair of Medicine at Rowan University. He's also the co-author of Compassionomics, which kind of sparked this episode in his latest publication, Wonder Drug. Steve, thank you so much for joining us today.
The pleasure's all mine. Thank you so much for the invitation.
Thanks, Steve. And not from Central Jersey. Not from
Central Jersey. I think Eric, I'll jump in right away and say, Steve, one of the things that brought us to you was certainly Eric Baumgartner on this call, who's our chief executive officer, a clinician by trade in the behavioral healthcare space. Eric and I have worked together for 15 years, and I find him to be one of the best leaders that I've ever had the pleasure of working with in our space. And one of the things that brought us to you was Eric reading your book, Compassionomics, and some of the things that we've since then have implemented, and some of the things Eric has really led us to through the lens of compassion. So, Steve, thanks for joining us. As I said earlier, I'm going to toss it to Eric because I know he's chomping at the bit to ask you a few questions.
Mike, I really appreciate you reading that introduction word for word that I sent to you earlier this morning. You nailed it. Thank you very much. Steve, as you have permitted us to refer to you as, I'm a huge fan. You are on my short list of heroes right now. You and your co-author, Dr. Mazzarelli. I've been in the behavioral health field for almost 30 years now. I've worked with children and adults. I've worked community based services. I've also worked in highly intensive residential settings as well. New Hope, our company, leans into both of those services and populations. I don't even know, honestly, how I came across your book. I think I was doing some kind of Google search for books, just kind of what my next read would be. I don't know whether I typed in healthcare leadership or trends in healthcare or whatnot, but your book came up. And the title actually really caught my attention. I think it's a great title. And it reminded me of the book I read decades ago, Freakonomics. I don't know if there's any relation there in your titling of it. But I think it was back November, December. I got your book, I started reading it, and probably 30 pages into it, I thought, this is the magic, this is the missing ingredient for us. I think is in working in mental health, working with kids and families, I think it's always a kind of an assumption that, well, of course you're going to be compassionate. But I love how the operational definition of compassion. I love the science behind, what the reinforcers are just chemically for us when we engage in compassion. I loved some of the stories that you had. There's one about a father who's also a doctor in an emergency room with his wife who's pregnant that just literally brings me to tears every time I read that story. To loving kindness meditation, something that we're leaning into as an organization to try to have staff primed and ready to go from the second that they start working with our youth and their families on any given day. I love that it's, compassion in your book is viewed kind of a 360 degree. It's not just towards your clients, the youth, the families, but it's also towards each other, those that you work with, how important that is, as well as the self-compassion as well. So I'm going to start you off with a question, if you don't mind. What got you started down the path of researching compassion in healthcare that resulted in your book, Compassionomics?
Thank you. Thank you for all that background and for the kind words. Our approach, Dr. Maz and I, that's Anthony Mazzarelli, my colleague and co-author. Dr. Maz is the co-president and CEO of our whole organization, and I'm the chair of the Department of Medicine at Cooper, and I'm an intensive care specialist. And we started a journey through the scientific literature for multiple reasons. One, is our board literally charged Dr. Maz with improving patient experience. And I'm a research nerd. That's one part of my bio that Patrick didn't read. And so Dr. Maz came to me and said, "Can you science this up?" And I thought, no, like, are you crazy? Like, we say the science and the art of medicine for a reason. And then when we actually started to look into it, we saw a signal in the data. And that signal was a bunch of studies that were probably below the radar, so to speak, or maybe they made a splash or a ripple, when they were first published, but no one had ever pushed all the data together to form a wave of evidence that caring makes a difference, and not just in meaningful ways, but also in measurable ways. So our MO, so to speak, is that it's not a heart story. And I love a good heart story as much as, you guys do and everybody else. But that's not how I was trained. I was trained as a clinician scientist. And rather than changing people's hearts, because especially the people that go into your field, I mean, people don't need a change of heart. You have your heart in the right place if you go into a field where you're serving kids with the scope of need that you've been sharing with me this morning. So no change of heart is needed, but if we do a good job of curating the scientific evidence, maybe we can change people's minds rather than changing their hearts. And changing your mind about the power of compassion, about your opportunities to use compassion every day. And when you see the data and you realize that there's a very robust evidence base behind treating people, patients, the way they ought to be treated, the way we would want to be treated ourselves. And you see that there is actual evidence that it's not just the right thing to do, it's also the smart thing to do, because it's the most effective way to treat other people. When you see that signal, you feel differently about your opportunities to treat people with compassion every day. And that's how I literally pivoted my entire research program. I had an NIH grant called an R01 to study resuscitation science. I spent the first 15 years of my career studying brain injury after cardiac arrest. And we had a grant to figure out what's the optimal level of oxygen in the blood to reduce the risk of permanent brain damage after resuscitation from cardiac arrest. And now I study things like compassion, service, and hope. So it's a bit of a change in trajectory, but it wasn't a heart story for me to make that pivot. It was really because we were able to see this signal in the evidence and following the science, really just following the science.
That's awesome. Like I said, I love the book. I'm going to hold it up just as a plug for you. Great book. Recommend it to anybody listening. Follow-up question. Tell us a little bit about the science behind compassion, how that translates in a healthcare setting. I think I kind of primed the studies that you all referenced around the brain and brain function and how you get a dopaminergic, if I'm saying it right, response when you do something for yourself, but it's so much more when you do it for someone else.
Sure. So I think the most important first step is to establish a common nomenclature. So what is compassion in the first place? Like, we have to have a working definition. So most researchers define compassion this way: an emotional response to another's pain or suffering or struggle involving an authentic desire to help. So it's distinctly different from a very closely related word, that's empathy. So empathy is the sensing and feeling and detecting and understanding component, but compassion goes beyond empathy because it involves taking responsive action to help alleviate a person's pain, suffering, or struggle to whatever extent is possible. And so an easy way to remember, and by the way, I need to be clear, empathy is vital, because if we don't sense, detect, feel, and understand, we will miss 100% of the opportunities to respond to someone with compassion. But an easy way to remember it is empathy plus action equals compassion. Empathy plus action equals compassion. And there are actually robust neuroscience data behind the distinction in terms. So when you bear witness to suffering, and experientially, we all know what that feels like. It feels terrible, right? Well, there's actually neuroscience data using functional MRI brain scans that shows that it activates the pain center in your brain. So there is neuroscience data behind the saying, I feel your pain, even though to some extent we all know that experientially. But it's also true that when using the same modality, functional MRI, that when the brain the mind is focused on finding a way to help alleviate, take action with compassion and to help in some way, a distinctly different brain structure is activated. It's not the pain center of the brain. It's what neuroscience researchers call the reward or a reward center of the brain. So positive emotion, positive affect, feelings of affiliation. And we know this experientially as well, because that direct activation of a reward center in the brain is part of the reason why it feels good to help people. And so there is a neuroscience basis for both empathy and compassion. Now, your question was, how does it work? Like, how does human connection work as it relates to compassion? Well, I think there are two separate and distinct questions. One is more broadly, like in relationships over a lifetime, and the other is in the context of healthcare, which might be episodic care. I mean, it could be longitudinal, of course, but it's not like relationships over a lifetime. And the reason why I make that distinction is the most important, in my mind, study of the power of human connection as it relates to health is the Harvard study of adult development. So this has been going on for 80 years now. They're on their fourth study director. They enrolled a few hundred kids way back when, and then since then have expanded the study to enroll their families and make it a much broader study. But the original cohort was half the kids were Boston teens who were not going to go to college, and half were enrolling at Harvard. And what they did is they tried to unlock what's the best predictor of good health and longevity. And so what they found is that the best predictor of good health and longevity into your 80s, it wasn't some biomarker in your 50s. It wasn't your cholesterol. It wasn't your blood pressure. It wasn't your blood sugar. It wasn't any of these things. It was actually the quality of your relationships, the quality of your relationships. And then we know the flip side of that is also true, because there's abundant public health data that loneliness kills. Being chronically lonely activates the stress response, fight or flight, cortisol release in the body, and you're basically living under constant stress when you're feeling lonely. Physiologically, it's the same thing in the body, and that can have an awful toll and sharply increase your risk of early death. The clinically relevant question is, what about short-term or shorter-term relationships in the context of healthcare, even if they're longitudinal relationships? And I like to start with the practical. So there are physiological responses and there are psychological responses, which are probably obvious to you guys in the field that you're in. But the practical just starts with self-care. So for example, if you care deeply about patients and they know it and they feel it, and this isn't just in your field, but broadly, if you care about them, they're more likely to take their medicine. They're more likely to follow treatment recommendations, and they're less likely to disappear and be lost to follow-up, which is sort of intuitive to most people. Like if we treat people the way we ought to treat them and the way we would want to be treated ourselves, they don't leave, or they don't, fail to follow. There's some intuitiveness there, but adherence to therapy is obviously big in all fields, including yours. There's also some evidence on quality of care, which are associations rather than they weren't designed to test for cause and effect, but where there's depersonalization, so a lack of human connection, quality metrics are typically lower, and whether they are just associations going in the same direction, it's basically a more likely than not a sloppy care, like lower meticulousness of care when people just don't care. And maybe that's also, at some point, everybody's had a colleague who didn't seem to care very much. And if you look at the quality of work that they do, it's not very high quality. So there are physiological responses as well for human connection. So a person's experience of pain, for example, that's just one that I could briefly touch on. So for example, and this is known from experimental science in laboratories of people undergoing experimentally induced pain. And I have no idea who volunteers for that kind of research, but it's done. And what it shows quite clearly is that the touch of a trusted other can reduce a person's experience of pain to some extent that is measurable in the confines of an experiment. So of course, I'm not saying compassion eliminates pain, because we all know that's not true. But to an extent that is actually measurable, I find it fascinating that compassion can modulate to an extent that can be measured. But that's also been shown in clinical medicine. Patients with low back pain undergoing physical therapy, patients with postoperative pain, patients with irritable bowel syndrome and abdominal pain related to that, patients with chronic headache pain attending a migraine headache clinic. Lastly, the last mechanism or category would be psychological. And you all know that compassion has been forever considered to be a cornerstone of the therapeutic relationship, whether it's therapist, patient, psychiatrist, psychologist, patient, nurse, patient, like whoever's involved, it is a cornerstone. And specifically, the most interesting signal from that data that I've come across is the data on demoralization among patients that suffer from depression. And demoralization is like one's depression about their depression, like the feeling like I'm never going to get out of this. And so in that way, compassion is a powerful restorer of hope.
That's sorry, go ahead.
So collectively, we're trying to take compassion out of the domain of the, quote unquote art of medicine, which is the nicest thing that somebody might call it. They may say it's the touchy-feely stuff.
Right.
And after you see all the evidence laid out, though, it's more like a duh. Like, of course it matters in measurable ways. It's just that, we haven't been very rigorous in medicine about putting rigor to it and trying to figure out how much. So like there's all sorts of things in medical education that are, supposed to make us more well-rounded and all these things. And I'm such a research nerd that if I can't boil it down to a beta coefficient or an odds ratio and confidence interval, like I'm just not super interested, because that's just how my brain works. But to relegate compassion to a nice to have is not only not the right thing to do, it's actually not evidence-based, and it's bad medicine.
25 and 12. Simple, seemingly ordinary numbers, but these numbers hold a special meaning at New Hope and prompted us to take action. 25, the percentage of young men diagnosed with an autism spectrum disorder, a number that is growing. 12, the average number of months families must wait for specialized residential treatment. But those days are over. Welcome to New Hope's Learning Enriched Autism Program, or as we like to call it, LEAP. New Hope may not change the 25, but we're impacting the 12. We're expanding this program from 6 to 20 beds, investing in the highest quality of treatment models and support systems. LEAP's team of specialists combines the best autism research with trauma-informed care and relational connections to create an environment where our youth thrive. At LEAP, youth learn the skills to reintegrate into their communities and chase their dreams. Families receive the support and resources to ensure this is the last residential treatment they'll ever need. With our enhanced program, the number that holds the most meaning to us now is 40. That's the number of successful LEAP graduates we anticipate annually. That's 40 lives changed. That's 40 families finding new hope through LEAP. That's our name. That's our promise.
So Mike and Patrick and Matt know how excited I am that you are on today. So I'm sorry. I'm going to try not to cut people off. I'm going to say one more thing, and then I'm going to open it up to the rest of our awesome team to ask you some questions. But taking it back to the actual caregiver or professional, when we started down this this path of what we call a culture of compassion, that's kind of our. This is what we're doing. We're doing a culture of compassion. And we actually came up with a slogan, start with compassion, and I modified it a little bit. I don't know if you can see it. It says start with Compassionomics. I just wrote it down and stuck it up there because again, I love your book and I love what you've done with this subject. But one of the things came out when we started kind of sharing it outside of our team was we got some, well, what about compassion fatigue? And I thought, that's a pretty interesting question, because what I've read in your book is that compassion is actually a protective factor against burnout. And so I went and looked in some other places, and I was just, you might have seen me, I was trying to find my notes because I did a presentation on this to our organization recently. But there's a study out there that actually says compassion fatigue is the wrong title. That's missed the mark, that it really should be empathic distress. That when you start with empathy and you end with empathy, it sends our system, it sends the process in a wrong direction. But compassion really is that protective factor. Is that, I just want to say that. If you got any comments on it, great. If not, we can move on to our other team members. But that was
I could talk to you about this for an hour.
Yeah.
I will give you, because I think this is super important, that I don't have the 30-second soundbite for this, so it's going to take me a few minutes to get there, but I'll get there, I promise. Okay.
Take time. No worries. Go for it.
Okay. So the other part of the answer to your initial question, how do you get involved with this, is that I found myself in the fog of burnout myself after 15 years of working in the ICU at that time. Now it's been quite a bit longer. My practice is different than yours. I know you see a lot of people who go through really serious trauma. I see people on a different type of worst day of their life. But after doing that for a long time, I became keenly aware that I've had every symptom of burnout myself, which sort of lines up with what you're saying about compassion fatigue and whatnot. So what I was taught in medical school, literally, I won't say where I went, but it's a really big Big Ten school. I was taught, don't care too much, because too much caring burns you out. And when I talk to doctors, who have gray hair like me, they all nod. Like, yeah, we were all taught the same thing. Because there was this dogma that it's like, don't get too close or you might get burned kind of thing.
Yeah.
And that was based on anecdote and conjecture and stories. And imagine my surprise when, in the throes of burnout myself and starting to investigate this in a rigorous way, I found that 80% of the published studies did show an association between compassion and burnout, but it's inverse. Meaning what I was taught in med school would be high compassion, high burnout, low compassion, low burnout. But 80% of the published literature shows high compassion, low burnout, low compassion, high burnout. So where stories once reigned, now there was actual research. And why is that? It's because when you care deeply about patients and they know it and they feel it, you get the relationship that flows from that. You get a deeper relationship that flows from that. Because I think what we're talking about is all about relationships. And if it's one thing that Dr. Maz and I have found over the last 5 years of studying this, is that the key to resilience is relationships. The key to resilience is relationships. And so what I tell, like young nurses and people coming up through the medical ranks, like if you care deeply about patients, you get the relationship that flows from that, you get the good part of what it means to take care of people.
Mm-hmm.
And if you don't have that, then all you've got is this super stressful job. And so I decided based on, based on the data, really just following the science, I was going to do my N of 1 experiment. So there was just one study subject, that was me. And I decided I was going to very intentionally, that is, care more, not less, lean in rather than detach and pull back. Because what I didn't really realize is that I'd been slowly detaching from my relationships over time. And the conventional thinking was like, take more nature hikes, go on vacation, do hot yoga, put on your headphones and your meditation app and block out the world, things that are very like isolating, like going deeper withinward. And there's tons of data for that too, that that is people's self-care strategies now. It's more going deeper withinward, whereas in decades past, we found solace in like family and friends and more connection, not in less, not in going withinward, but reaching out. And so that was what I found in my N of 1 experiment, is that I very intentionally cared more, not less. And that was when the fog of burnout began to lift for me. And it's because I got the relationships that flowed from that. So it wasn't just deepening relationships with the nurses who I'd worked with for, almost 20 years at that point, or with my trainees or my colleagues, but even with my friends and even at home. And that's when the fog of burnout began to lift for me. So some people will say, yeah, but how does that comport with, to your point, about this question of compassion fatigue, which came out of the nursing literature, which I have great respect for. It's that, but it's important to recognize that there are some robust neuroscience data that have resolved this for me, at least in my mind. And there is a researcher by the name of Tanya Singer at the Max Planck Institute for Neuroscience in Germany. And she studied this with brain imaging, but the conceptually, what she's come up with is what's been known for quite some time, but she put a moniker on it: self-other distinction. Self-other distinction. And so when I meet people and their families on the worst day of their life, I will when I walk into the room and I assess the situation, and the self-other distinction says, this is a tragedy. It's not my tragedy, however. And yet, rather than walking away or running away or just trying to numb myself to what's going on here, what I'm going to do is look for a way to be helpful to these people in some way that is meaningful to them, as small as an opportunity as that may be. And you get the deeper relationships that flow from that. So I'll tell you a story, because I think it's maybe not so a while back, I was rounding in the ICU with the team, students, residents, fellows, and we had an especially depressing ICU service. Basically, it was a whole line. It was basically one not fixable problem after another. And, patients with terminal conditions that we were able to diagnose either when they were in the ICU, and realizing that these patients didn't have a lot of time left. And one of these gentlemen, we were able to get him off the tube, off the ventilator. He was breathing on his own. And I noticed that he was just, fighting to get his eggs up to his mouth, eating his breakfast. And it was so frustrating to him. And I broke off from rounds a little bit and went over and, started helping him. The poor guy just wanted his eggs, he just wanted his eggs. And the smile that once I helped him get those eggs in his mouth, you would have thought, like, we connected a little bit, he was able to talk to me and whatnot. And I remember one of the resident physicians said, "Hey, Dr. T, listen, you don't have to do that. We've got other people that can help him eat his eggs." And I'm like, bro, you do not get it. This is my big chance this is the biggest chance I have today to do something that's meaningful for him. Because it wasn't just that I helped him eat, it was enough that it was because he recognized that I stopped what I was doing that day
Yeah.
because it was important for him. Right. And he felt seen in that moment, and he gave me little jokes and whatnot. So the point is, what I'm trying to say is that if you just find some little things that you can focus on, and you focus on it, and you work on delivering that for somebody, it can turn I love the term empathic distress. I've heard that a bunch of times myself, and I just wrote it down again, because when you're just absorbing other people's vicariously absorbing their pain, but you're not able to move the needle for them in a meaningful way, then you just get that activation of the pain center of your brain, and you don't get the activation of the reward center of the brain. So I agree. I used to call it empathy fatigue, not compassion fatigue, but empathic distress is a better term, and one that's evidence-based as well, because people use it in the scientific literature. But it's actually taking action. And even if you listen, I had no capacity to move the needle on his terminal diagnosis. But what was meaningful to him right there in that moment? You know what I mean? And that then, when I was on a very depressing ICU service, that was like the highlight of my day. Right.
Right.
It's those huge, small things like that I think we as an organization, we're doing better with it, but preaching and teaching and guiding our direct care staff. We work with some very hurt kids, and sometimes it's hard to see how you might be having a positive impact on a child when they're cursing at you or spitting on you, but I guarantee you every day at New Hope there's a miracle that happens, or there's hope that's given.
But we also work with hurting staff,
Yeah.
as does Steve. And the family may not have been in the ICU at that moment, but the rest of the team saw his actions and probably had a profound moving of the needle on their compassion and the meaningfulness of it. I think those are things we also have to keep in mind as well. We talk about modeling all the time.
So everything that I share with you guys, or in our books or whatnot, we have a citation, a reference in the literature, except the one I'm going to tell you right now. So I always like to tell you when something's just my opinion rather than something I can back up with evidence. But what I tell my resident physicians, we've got 85 of them in internal medicine, and I tell them, hey, if we do a good job of taking care of each other, how we take care of patients and their families will be just fine.
Right.
Mm-hmm.
And it's probably intuitive to you guys why that is the way it is. But I really think that what Dr. Maz and I have been working on lately is the message that, yeah, we need to do a better job of compassion for others, but it starts, with taking better care of each other.
Mm-hmm.
And, it's not like the residents have to be best friends or go out to dinner every night. Right. But hey, I heard your mom was sick. I'm really sorry to hear that. Can you give me something that I can take off your plate today? Things like that, just, let people know that they're not going through it alone. And, people carry, the older I get, the more I just realize, like, I am just blown away by the amount of pain that people carry around, and you just never know it because they got the poker face on. You know what I mean? And when I was in the throes of my burnout, I mean, I asked people after that, on the, even some who are my best friends are like, yeah, we never knew, which scared the heck out of me. You know what I mean? That was I thought everybody could tell, by the way, everybody. I thought it was obvious and everybody was talking about it. Right. And they're like, no, you actually faked your way through it for years, So
Steve, I'm glad you actually took that time to tell that story, because that's a powerful story. And there's been a few times where I think you referenced that things might be more natural in behavioral health than in the med. I don't know if they actually are. I think there's so much commonality here in what we get wrong and what we get right between our corners of the sandbox that I think it's profoundly impactful. I am curious because like you said, you're kind of trying to bridge. We used to think of these things as art and science, and you're kind of knocking down that wall with this research. Book came out in 2019. How was it initially received? How's it been received since? What kind of impact do you feel like you had? I think we had a pandemic somewhere in there, so I don't know if that did anything. But just what's it been like the last 6 years? Are there people who are still like, hey, that research that Dr. T is doing, that's kind of just that's gobbledygook, that's touchy-feely, that doesn't have an impact? And has there been any places that have really embraced it at scale?
Yeah. So first of all, I love what I do. And when I was in the throes of burnout, I was like trying to figure out, okay, how many years do I have left before I can retire? As long as, everything goes okay. I love what I do now. So I don't need like any accolades or validation. I just love the work, to be honest. Maybe that's just because with getting older, you get a little bit more mature about stuff and you realize that, accolades don't matter. That being said, we are making a lot of inroads. I'll tell you about those in just 1 second, but first I have to also tell you, you guys might have sensed this from our pre-podcast banter, but I'm also fluent in sarcasm. So when some of my colleagues, especially some of the curmudgeon-like colleagues that I've practiced with alongside for 20 years, would take a shot at me of some sort, said thing, trying to frame the work that we're doing as touchy-feely or whatnot. I say, well, which of the 280 original science peer-reviewed published papers did you have a problem with? So like, in other words, my fluency in sarcasm is to try to frame it back. Like, look, if you don't think that, listen, there's as much evidence for treating patients with compassion than any pill you guys put in your mouth this morning.
Right.
Okay. I mean, I took my antihypertensive and that's obvious, standard of care medicine, but there's as much evidence behind treating people with compassion as anything else that we consider to be conventional care. Yeah. So I don't back down from anybody. So that my sarcasm is, comes out in that way. But to be fair, our message has highlighted just within the past 12 months, the deans of all the medical schools, their annual meeting, the biggest graduate medical education meeting in America, and so among others, so the message is resonating with people, but not because of definitely not because of the people carrying the message. Let's put it that way. Okay. It's because the message is just evidence. And so we have been for a long time now relying on evidence-based medicine, and you rely on evidence-based practices in your work. And so it's just realizing that the evidence is there. So here's the best way I could answer your question. What I'm sharing with you guys today is what I tell my own daughter.
Yeah.
So my daughter, Isabel, is going to medical school right here at Cooper Medical School of Rowan University in 2026. And what I'm sharing with people is would I ever lie to my own daughter? Of course not. I tell her, follow the science. He said, because if you follow the science, it'll lead you to compassion. If you follow the science, it'll lead you to serve. And if you follow the science, not only will it lead you to a career that is long and quote unquote productive, it'll lead you to a career that is more fulfilling than you can possibly imagine. So yeah, I'm not I'm not the fold 'em kind of guy. If somebody wants to debate, I'm happy to double down anytime.
It's interesting that you have a daughter named Isabel. I also have a 5, almost 6-year-old daughter named Isabel. And sometimes I think she teaches me and she teaches my wife more about compassion than we teach her. And I think she's one of those individuals that just it's innate for her. But anyway, I just thought it was interesting that you also have a
Totally.
daughter of the same name. I wanted to give you an opportunity to talk about your other book, Wonder Drug, and I like this, I guess it's a subtitle, Seven Scientifically Proven Ways That Serving Others is the Best Medicine for Yourself. I'm
Yeah.
assuming some of that must have also come out of your burnout journey. And is that also, is this kind of a sequel to Compassionomics?
Yeah, it's a sequel. It's really a single through line, but connecting the two. And we have a third one that's going to be coming in 2026. So my N of one experiment changed everything for me. Like if you guys would have met me in 2017, like you would have met a very different person. So it changed everything for me. And the science shows it can change everything for you too. And the science also shows that the minimum effective dose, so to speak, is probably only like 40 seconds. Could it take longer than that? Oh, of course. But if we want to be evidence-based about it, that's a minimum effective dose. So after writing Compassionomics and telling the story of my N of one experiment, we got messages from all over the place, people saying, I tested the compassion hypothesis for myself and I got the exact same results. And so then we're like, okay, there can't be anything unique to somebody who's a frontline healthcare worker and puts on scrubs every day and goes to work in a hospital, right? There's got to be a universal, or perhaps there's a universal. That's what we're testing, the hypothesis. And really the question for Compassionomics was, does compassion really matter? Does it really matter, or is it just a nice to have? For Wonder Drug, the question is like, what's the evidence-based way to live your life? Is it all self-absorbed and absorbing yourself, or focused on other people? Mm-hmm. And it was really an experiment, my N of one experiment, leading to all these other people's explanations. And we curated all the evidence that being other focused, rather than turning your attention like constantly on yourself, turning on other people and getting out of your own head and ruminating on your own stuff and focusing on other people, does it make you healthier? Does it, on average, is it a protective factor in terms of risk for mortality? Are there specific health outcomes? What about mental health? What about happiness and well-being? And what about professional success? And what we curated was another 250 original science research papers, and to synthesize the evidence that as we say, serving others is the best medicine for yourself. So a live to give kind of mindset is actually good for you, in not just in physical health, but mental health, well-being, and even professional success. And so and I want to be clear, because people always say, well, isn't that like obvious? Well, I would say that almost all world religions or philosophies have had incorporated some thinking that kindness for others is at least a virtue, right? And so what I would say is what we describe has been true from the very beginning. It's just that the researchers, they didn't create the truth or any kind of new thing. They just shined a light on a truth that was true from the very beginning. And so it's the way I look at it is that science is just catching up, so to speak.
Yeah.
And, there's a lot of evidence that, because when we say there's scientific evidence that serving others is the best medicine for yourself, whether you have a biblical worldview or some other worldview or just secular humanism or whatever it is, people say, well, duh. And I said, okay, well, maybe that's a duh kind of thing, but what are the trending things in society now, right? It's all about me.
Right.
And the message, there's two sides of the same coin. One is that focusing on others actually will improve all these things in your life. The other is, if it's all about you, you have a sharply increased risk of being miserable and being unhealthy and having lower professional success and all these things. So this is what I teach my kids.
And that's why I think your books are transcendent. I mean, this is not just about healthcare. This is about everybody. And I think that's the part that resonated so much with me.
Yeah, the humbling thing about it is just realizing, like, these researchers didn't create anything.
Right.
They just exposed it. And all we did, like, so for example, there's nothing specifically virtuous about our work, which is this, just rolling up our sleeves, right? Digging through all the papers, and then, writing it up in a way that we hope is engaging for people and not too nerdy or anything like that, right? But yeah, this work's changed everything for me. And so the new book, it's not so new anymore, but it's way better than Compassionomics, to be honest with you. But yeah, it's been it's meaningful for both Dr. Maz and I.
At New Hope, we believe that culture is everything. Residential services is what we do, but culture defines who we are. Sadly, poor culture issues are at the heart of unfortunate incidents involving staff and kids in residential programs all across the country. These incidents have led some to question whether residential services should even have a role in our mental health system of care. This is why, at New Hope, we are called to be different. We are called to stand out from the crowd. Our kids' experiences will be a direct reflection of our culture. So, let's name it and let's build it.
We are committed to a culture of positive relationships. Relationships that are built on trust and care for our kids, each other, and the community.
We're committed to a culture of teamwork. We always ask, how can I help? And we never say, that's not my job.
We are a culture of fun and laughter. We take our work seriously, but not ourselves too seriously.
We are committed to a culture of shared excellence. Leaders are always coaching, so team members are always growing.
That's the New Hope culture. Our goal is to be the best provider in the country, and our culture demands that everyone is passionately rowing in the same direction, at the same speed. We call these commitments because the culture is continuously created and maintained by our actions every day. It's not static. It's a living, breathing thing. It's built in every conversation, every email, every conflict, every interaction. You, watching this video, are either actively building this culture or actively working against it.
I'm committed.
I'm committed.
I'm committed to building the culture.
Attention New Hope staff and all communities. We have a successful discharge in the lobby. Please put your hands together and show your love for Joshua.
I'm committed to building a culture at New Hope that everyone wants to be a part of. My question is, are you in?
Well, Steve, I think we could probably continue this conversation for hours, if not days, but being respectful of your time, I'm going to give you a chance now to encapsulate your overall message and kind of hammer home the things that are most important to you. Hit you with this before we started recording, but I'm going to ask you now, for you, what is the stuff that matters?
So I'll answer it in one word for what matters right now. And I'm not pandering to the fact that it's in the name of your organization, but I think that what matters the most right now is hope. And I don't mean that in a Pollyanna, wishful thinking, gumdrops and, unicorns and all that, right? I mean it in a very real way. So our next work, which will be a forthcoming book and released in 2026, is going to be about the science of hope. And the question is what is hope? What it is? What is it? What isn't it? When does hope matter? When it matters, how much does it matter? What's the responder phenotype? Like, who are the people that respond to hope? And to take as rigorous of a scientific inquiry into hope as we possibly can. Hope is, the researcher's definition of hope is the belief. So that's the first key. It's a belief. So it's not a feeling or an emotion or anything like that. It's the belief that tomorrow can be better than the today. And importantly, as it relates to this concept of hope theory, we play a role in making it so. We play a role in making it so. And it's different than a wish, like wishful thinking, because that's believing, the term commonly assigned to that is optimism. So that's like, well, I think everything's going to work out, but I just have no idea how, right? So hope, in contrast, is a goal-directed belief that's based not only on future casting of a better tomorrow, but also pathways thinking to figure out how are we going to get there. And I'm sure there's going to be roadblocks. So we need to have a plan A, B, C, D, and E for when we hit these roadblocks. But then lastly, the agency, or just having the willpower to stay on the path when the path gets really hard. And there is evidence in healthcare and medicine about better health outcomes for people who have hope for recovery, what is often termed recovery expectations. There's evidence, especially in cardiovascular disease, that hopelessness can basically double your risk of early death due to cardiovascular disease, among many other risk factors, of course, like the usual ones, smoking, diabetes, cholesterol, all these other things. Hopelessness also moves the needle in a meaningful way. So hope matters, not just in meaningful ways, but measurable ways. I think right now it is, there's a lot of people struggling with hope right now.
Yeah.
And that's, not a statement through one lens or another. It's just in general, people are struggling with hope. And that is, so for example, a CDC study just recently reported that 40% of teenagers right now are having persistent feelings of hopelessness. I didn't say sad, right? Hopelessness. And especially as for the younger generations that are, how am I going to make it? How am I ever going to buy a home? How am I going to ever, or people who are struggling with something really heavy, like the folks that you serve, the kids and their families that you serve, are dealing with really heavy stuff. There's a brilliant researcher by the name of Chan Hellman and his colleagues at University of Oklahoma that have done extensive study on hope in the type of at-risk youth that you serve, and has shown that hope is a powerful predictor of better outcomes measured in many different directions, some clinical and others, in other ways to measure life outcomes. But the most important thing I can tell you is that a lot of people, the third part of that hope mindset is agency, as I said, so willpower. And I struggled with that for a long time before I really got deep into the science. And the reason why I struggled with it is because to me, it sounded like too motivation-y, like a motivational speaker, like, oh yeah, just, you can do it, right? Well, the truth is sometimes you can't do it. But if it's one thing I've found from this work so far, and we're not all the way through it yet, but it is this: there is power in the agency of others. There's power in the agency of others. So when patients come to my ICU, quite frankly, a lot of times they're in a coma. They're hooked up to life support. They don't even know I'm in the room, right? Their families do, but do they really have agency to impact the outcome? Or is it, we just met with Dr. T and his team, and they know what they're doing, and they're gonna around the clock give us the best chance to make it out of here, right? There's power in the agency of others. And the reason why I tell you that is your teams, there's power in the agency of your people that are serving these kids who are in need. And sometimes the kids don't, have their own agency, but if they can, if your people can get them to believe in the agency of your people, that's a big step in the right direction. So that's a long way of saying I think what matters right now is hope, and hope isn't some like fantasy Pollyanna, woo-woo kind of thinking. Hope is powerful. Hope is real. And it's important for us as leaders to practice hope. So there was a recent Gallup poll that asked people to think of the most of the best leader they've ever had in their life. And it asked them to list the qualities of those people. And then what they did is essentially they made like a histogram of like what were the most common, traits. And so one was compassion. Okay. One was trust. One was being steady, right? Like predict, not up and down, but steady. Those three are predictable. If you put those three, the frequency of those three things together, it was outweighed by the number one, and that was hope. Wow. Hope is powerful in leadership because it helps people see a vision for what they're trying to do, even if the day-to-day is like just hand-to-hand combat trying to get through the day, right? And in your field, sometimes it literally might be hand-to-hand combat, right? Yeah. And I'm not trying to be funny or something. Like that's real. That's the reality of the hard work that you all are doing. Yeah, hope matters. I'll leave it at that.
Well, I'm not sure how to end it better than the words you just shared. I think I can confidently speak for everybody on this team. I mean, we work for New Hope for a reason. And if on a great day or on any day, giving hope to kids is what drives each and every one of us and our teams. I mean, this was what this was all about, Dr. T, was Eric leading us with some stuff from your book that we can bring to the direct care staff who are face-to-face with those kids that really need our help. This conversation, Patrick mentioned it, we could talk to you for days. I hope maybe one day we have a second or third episode with you. You've been so gracious with your time. I don't know how to say thank you enough, but this was absolutely wonderful.
Thank you for the kind words. It means a lot to me.
Thank you so much, sir.
Thanks much, Steve. Thank you.
Thank you.
Thank you.